Welcome to our video on small bowel obstruction. Let's begin. We will cover the definition, pathophysiology, etiologies, clinical presentation, diagnosis, and management of small bowel obstruction. First, let's take a look at the definition of small bowel obstruction. A mechanical small bowel obstruction occurs when there is an intraluminal obstruction or extraluminal compression that prevents the passage of small bowel content. There are several specifiers for the type of small bowel obstruction. First is to determine if the obstruction is partial or complete. A partial obstruction allows some intestinal content to pass through the blocked segment of bowel. However, a complete obstruction results in a total blockage of the small bowel with no passage of intestinal content. Another specific type of bowel obstruction is a closed loop obstruction. This type of obstruction is unique because it occurs when a segment of bowel is obstructed at 2 points, resulting in a closed loop of bowel where no material can enter or exit. After determining if the obstruction is partial or complete, one can determine if the obstruction is simple or strangulated. If the bowel obstruction is simple, there is no evidence of bowel ischemia. However, if the bowel is strangulated, it means that there has been a compromise in blood flow leading to ischemia and necrosis of that portion of bowel. A strangulated bowel is typically associated with more severe abdominal pain and with localized tenderness. In addition, there may be other signs of a more severe obstruction with strangulation, such as fever, tachycardia, and leukocytosis. When there is obstruction of the bowel, there are changes in the bowel proximal and distal to the blockage. Proximal to the blockage, there will be progressive dilation and increasing pressure, and intestinal contents and fluid become backed up. The intestine responds by increasing peristalsis to overcome the obstruction. These peristaltic waves are what lead to the colicky abdominal pain associated with obstruction. Distal to the site of obstruction, there will be decompression of the bowel as the intestinal contents distal to the site of obstruction continue to pass while anything proximal to it cannot. As the bowel continues to become more and more dilated due to the obstruction, it will also become edematous and begin to lose its absorptive function. This leads to fluid accumulation in the lumen. As the small bowel obstruction progresses, it can lead to ischemic necrosis of the bowel. This can occur if a portion of the bowel or mesentery twists around an adhesive band or other attachment, compromising the vasculature. In addition, the excessive bowel dilation and edema can compromise vasculature. The resultant ischemia and necrosis compromise the bowel wall, increasing the permeability. This increased permeability allows intestinal microbes to translocate across the bowel wall into the abdominal cavity, and can result in sepsis. In addition, the ischemic and necrotic bowel can perforate, releasing intestinal contents into the abdomen. This can lead to inflammation of the peritoneum, causing peritonitis. Finally, the anaerobic metabolism associated with the ischemic tissue leads to the formation of lactic acid. A 57-year-old woman is brought to the emergency department due to intractable vomiting and abdominal pain for the past day. Her past medical history includes cholecystectomy for acute cholecystitis. She has not had bowel movements for the last 3 days. Her vital signs include a blood pressure of 85/70, heart rate of 130, and respiratory rate of 13. Abdominal x-ray reveals dilated duodenal and jejunal loops with air fluid levels, and a gasless ileum. Which acid-base disturbance is most likely present in this patient? This patient presents with vomiting, abdominal pain, and absent bowel movements for the past 3 days. Her abdominal x-ray reveals dilated duodenal and jejunal loops with air fluid levels and a gasless ileum. Considering that she has a history of cholecystectomy, she likely developed intraperitoneal adhesions. Intraperitoneal adhesions in turn led to recurrent bowel obstruction. Her vital signs reveal hypotension and tachycardia, likely due to intractable vomiting. Severe volume depletion activates renin-angiotensin-aldosterone system and causes contraction alkalosis with hypokalemia. Additionally, this patient is losing chloride by vomiting the gastric acid, so she likely has hypochloremia as well. Therefore, the acid-base disturbance most likely present in this patient is hypochloremic metabolic alkalosis. However, please keep in mind that if bowel obstruction is so severe that it compromises blood flow, it can lead to ischemic necrosis of the bowel wall. Prolonged tissue ischemia and anaerobic metabolism can result in lactic acidosis, just as we discussed in the previous slide. There are several different etiologies of small bowel obstruction. First, there are conditions that lead to extraluminal compression. The most common cause of bowel obstruction is adhesions from prior surgeries of inflammatory processes. These adhesions create areas that the bowel can twist or kink around, leading to obstruction. A volvulus can lead to extraluminal compression when a portion of bowel twists around itself and its mesentery, causing a closed-loop obstruction. Other causes of extraluminal compression are incarcerated hernias, intussusception, and superior mesenteric artery syndrome. An incarcerated hernia occurs when the intestines herniate through the abdominal wall and cannot be reduced back through. This leads to an obstruction of this portion of the intestine. Another cause of obstruction is intussusception. This occurs when a proximal portion of the small bowel telescopes into a distal portion, compromising the lumen. Intussusception is commonly associated with a lead point. This lead point is the area that becomes stuck during peristalsis and drags the proximal bowel forward into the distal portion. The most common lead point in intussusception is a Meckel diverticulum. Before I go any further, I'd like to mention that this image was contributed by Amboss. Thanks to our partnership with Amboss, I can highlight several important features of strangulated hernia. So here's an illustration representing a hernia. This is the abdominal wall, and these are the intestinal contents that have herniated through the wall. A hernia becomes incarcerated when the intestinal contents cannot be reduced back into the abdominal wall. If the hernia becomes strangulated, the blood flow of the segment of intestine stuck outside of the abdominal wall is disrupted, and the tissue becomes ischemic. This can also lead to a section of closed-loop bowel obstruction, since there will be 2 points of obstruction. Another potential cause of extraluminal obstruction is superior mesenteric artery syndrome. This occurs when a portion of the duodenum becomes trapped between the superior mesenteric artery and the aorta. Typically, this area of the duodenum is protected by an abdominal fat pad to prevent compression. However, if a patient experiences significant weight loss, they can lose the abdominal fat pad that surrounds the duodenum, allowing the duodenum to be compressed between the superior mesenteric artery and the aorta, resulting in obstruction. Here is an image showing superior mesenteric artery syndrome. On the left, one can see an image of the normal anatomic relationship between the superior mesenteric artery, aorta, and duodenum. Take a look here at the mesenteric fat that protects the duodenum. Now, take a look at the right. This illustration shows that the anatomy in a patient who has experienced extreme weight loss, leading to loss of the mesenteric fat. This allows the superior mesenteric artery to compress the duodenum, leading to a small bowel obstruction. Now that we have covered extraluminal causes of small bowel obstruction, we can mention some of the causes of intraluminal obstruction. First, tumors within the bowel can lead to obstruction. Patients may also have strictures that cause a decrease in the diameter of the bowel lumen and contribute to obstruction. These strictures are most commonly associated with Crohn's disease. Patients can also have obstruction of the bowel secondary to gallstones or foreign bodies. The clinical features of small bowel obstruction include nausea, vomiting, colicky abdominal pain, and abdominal distension. In addition, patients may experience constipation or obstipation, which is a complete inability to pass stool or gas. Patients may also present with signs of dehydration secondary to vomiting and loss of fluid in the bowel lumen. These signs can include tachycardia and orthostatic hypotension. The change in bowel sounds depends on the timing of the physical exam. If the patient is presenting early in the course of small bowel obstruction, they will have increased high-pitched tinkling bowel sounds as peristalsis increases in an attempt to push contents past the blockage. However, if they present very late in the course, they may have decreased bowel sounds as the bowel becomes more dilated and loses peristaltic function. There are several metabolic derangements associated with small bowel obstruction. The metabolic derangements are associated with 2 consequences of small bowel obstruction: vomiting and third spacing. Patients with small bowel obstruction will typically lose significant amounts of fluid while vomiting. In addition, as the bowel becomes edematous and loses its absorptive function, there will be a loss of fluids into the bowel lumen, which is known as third spacing. When the patient vomits, they lose sodium, potassium, hydrogen ions, and chloride. This eventually results in a hypovolemic state with an associated hypokalemic, hypochloremic metabolic alkalosis. The laboratory evaluation for a small bowel obstruction should include a complete blood count, basic metabolic panel, serum lactate, and arterial blood gas. A complete blood count is used to evaluate for leukocytosis, which may be a sign of more severe bowel obstruction with complications such as perforation or necrosis. A basic metabolic panel will help to establish the severity of hypovolemia and electrolyte abnormalities. Serum lactate should be ordered in order to determine if there has been any ischemia. An arterial blood gas can also be ordered to determine if there are any acid-base changes associated with the obstruction. Remember from earlier in the lecture that the vomiting associated with a small bowel obstruction can lead to a hypokalemic, hypochloremic metabolic alkalosis. However, if there is ischemia and necrosis creating lactic acid, the patient may be experiencing a metabolic acidosis. The initial imaging for a suspected small bowel obstruction is an abdominal series. This includes an upright chest film, upright abdominal film, and supine abdominal films. Each of these images can evaluate something different in the context of small bowel obstruction. A chest radiograph can be used to investigate for free air above or below the diaphragm, which would be indicative of a perforation. An upright abdominal radiograph can reveal air fluid levels in the small bowel and the presence of air in the colon. If there is air in the colon, it indicates there is not a complete bowel obstruction and that some air is passing through the obstruction. A supine abdominal radiograph can be used to estimate the extent of the distension proximal to the obstruction by examining the width of the small bowel. This is a plain upright abdominal X-ray of small bowel obstruction. The way to tell whether it's a small or large bowel is by identifying the plicae circularis, which are these little white faint lines across the entire width of the small intestine. Plicae circularis are found only in the small intestine as opposed to the haustra, which is the hallmark of the large intestine and will typically only cross about half the width of the colon on radiographs. Here, one can see some of the signs of obstruction, such as multiple air fluid levels, represented here by the sharp horizontal lines, and dilation of intestinal loops, which can be seen right here. After obtaining an abdominal series, one can obtain an abdominal CT to confirm the presence of small bowel obstruction. On CT scan, one can visualize the transition point between the area proximal to the obstruction and distal to the obstruction. One can also see several signs on CT scan that can indicate the etiology of the obstruction. One can see the target sign, which appears as concentric circles, which is indicative of an intussusception. A whorl sign is indicative of the twisting of bowel around the mesentery, which is associated with a volvulus. Pneumatosis represents gas in the wall of the intestine, which is indicative of ischemia and necrosis of that area. In addition, one may see pneumoperitoneum on the CT scan, which is the presence of air or gas in the abdominal cavity and can be visualized as free air under the diaphragm, spleen, or liver. It is typically a sign of bowel perforation. On this CT, one can see dilated loops of bowel with air fluid levels, which is characteristic of small bowel obstruction. Here's an image from an ultrasound study of a patient with intussusception. The classic description of ultrasound findings in intussusception is a target sign, which can be seen here. The target sign consists of a hypoechoic outer ring, that is the outer loop of the distal bowel, and a hyperechoic inner ring, which is the proximal portion of bowel that has been pulled forward into the lumen of the distal bowel. Here is another imaging finding that can be associated with small bowel obstruction. In this upright chest X-ray, one can see pneumoperitoneum. Pneumoperitoneum occurs when a portion of the intestines perforate, allowing free air to become trapped in the abdomen. On upright chest X-ray, this air will rise and collect under the diaphragm. This can be clearly seen on the right side of the chest X-ray. Instead of laying flat on the liver, the diaphragm is raised up due to the free air. The green arrows in this image are pointing to the diaphragm, and the red arrows are pointing to the upper edge of the liver, which is visible now that the diaphragm has been lifted off of it. On the left of this chest X-ray, the blue arrows are pointing to a portion of normal, gas-filled colon. Let's take a look at our algorithm for small bowel obstruction. For now, let's focus on the left side of the algorithm, since we will cover ileus on our next lecture. When a small bowel obstruction is suspected, one should first obtain an abdominal series with plain X-ray, which can show the dilated loops of small bowel and air fluid levels. If these imaging findings are present with a history of increased bowel sounds, prior abdominal surgery, hernias, or abdominal masses, one should have a high suspicion of small bowel obstruction. Next, one should examine the X-ray and determine if there is gas present in the colon, or ask the patient if they have been passing flatus. If no gas is present and or the patient has not been passing flatus, then this is most likely a complete small bowel obstruction. If there is gas present and the patient has been passing flatus, then it is most likely a partial small bowel obstruction. However, a CT scan is needed to make a definitive diagnosis. Management of a small bowel obstruction can be conservative as long as it is a partial obstruction or a complete obstruction with no signs of ischemia. First, the patient should be rehydrated with IV fluids, and any electrolyte abnormalities present should be corrected. The patient can also have a nasogastric tube placed in order to help decompress the bowel, which should help with nausea, vomiting, and abdominal pain. The patient should also be NPO, or without oral feeding, in order to allow the bowel to rest and recover. We can also give analgesics and antiemetics as needed. However, the antiemetic metoclopramide should be avoided in small bowel obstruction since it can increase peristalsis. Increased peristalsis is not desirable in small bowel obstruction because the increased peristalsis can lead to perforation. In combination with an obstruction, finally, the patient should have their abdominal exam repeated throughout their stay in order to detect any changes such as new increased pain, guarding, or rebound tenderness. Surgical management is required for more severe small bowel obstruction. These include a complete obstruction with hemodynamic instability or sepsis, signs of ischemia or necrosis with labs or imaging, closed-loop obstructions, or obstructions that persist despite conservative management. Surgical management of a small bowel obstruction is an exploratory laparotomy in order to find and relieve the obstruction. In addition, any non-viable bowel should be resected during the procedure. Non-viable bowel can be found by looking for abdominal color, such as a bluish or dull tint rather than pink healthy bowel, the absence of peristalsis, and the absence of arterial pulsations in the mesentery. If there is a segment of bowel with any of these characteristics, it should be removed because it will not be viable. A 75-year-old man is brought to the emergency department due to severe abdominal pain and vomiting for the past 2 days. His last bowel movement was 4 days ago. The past medical history includes sigmoidectomy due to recurrent diverticulitis. His vital signs include a blood pressure of 70/60, heart rate of 130, and respiratory rate of 20. Arterial blood gases reveal metabolic acidosis with an anion gap of 20. Abdominal X-ray reveals dilated jejunal loops with air fluid levels and a gasless colon. IV fluids have been administered. What is the best next step in the management of this patient? This patient presents with severe abdominal pain, vomiting, and the absence of bowel movements for the last 4 days. Considering that he has a past medical history of sigmoidectomy, possibly leading to adhesions, this patient likely has bowel obstruction. Abdominal X-ray findings of dilated jejunal loops with air fluid levels and a gasless colon indicate a complete bowel obstruction. This patient is hemodynamically unstable with hypotension, tachycardia, and an anion gap metabolic acidosis, suggesting possible bowel infarction. IV fluids have been administered, so the best next step in the management of a hemodynamically unstable patient with bowel obstruction or infarction is exploratory laparotomy. Let's take another look at the small bowel obstruction side of our algorithm and review management. If the patient has a complete bowel obstruction, they should be taken to the operating room for an exploratory laparotomy. If the patient has a partial bowel obstruction but has any signs of bowel compromise, such as guarding or rebound tenderness, they should also be managed with an exploratory laparotomy. However, if it is a simple bowel obstruction with no signs of additional complications, they should receive conservative management only. A 60-year-old man is brought to the emergency department because of multiple episodes of bilious vomiting, diffuse abdominal pain, and bloating. The patient doesn't smoke, consume alcohol, or illicit drugs. On examination, there is a tender mass in his abdomen that can't be reduced by pressing. Guarding and rebound tenderness is also noted. His temperature is 38 degrees Celsius, heart rate is 110, respiratory rate is 23, and blood pressure is 139/85. Which of the following is most likely to be elevated in this patient? A. AST/ALT, B. Serum lipase, C. Serum urate, D. Serum lactate, or E. Serum potassium. From this question, you can appreciate that this patient's symptoms are typical for bowel obstruction, which include bilious vomiting, diffuse abdominal pain, and bloating. He likely developed bowel obstruction secondary to incarcerated hernia, suggested here by the tender masses in his abdomen that can't be pushed back by pressing. The strangulated hernia likely also resulted in ischemia, necrosis of the intestinal tissue, and peritonitis, manifesting here as rigid abdomen, guarding, rebound tenderness, and signs of distress like fever, temperature is 38 degrees Celsius, tachycardia, heart rate is 110 beats per minute, tachypnea, respiratory rate is 23, and elevated blood pressure, which is 139/85. The ischemia and necrosis of the intestine can lead to an increase in lactic acid, as this portion of the bowel undergoes anaerobic metabolism. Therefore, the correct answer to this question is D, increased serum lactate. Here's an image to remind you of the anatomy of an incarcerated hernia. Remember that the tissue within the hernia can become strangulated if the blood supply is compromised, leading to ischemia and necrosis of the intestines. Let's review the other answer choices now. Elevated AST/ALT is seen in the case of alcoholic hepatitis. The patient doesn't drink alcohol, which makes this answer less likely. Elevated serum lipase is evident in the case of acute pancreatitis, which is less likely since it typically presents with epigastric pain radiating to the back and wouldn't explain the non-reducible abdominal mass. Elevated serum urate can be seen in tumor lysis syndrome and some other metabolic disorders like gout. However, uric acid levels is not necessarily increased in bowel obstruction or incarcerated hernia. Elevated serum potassium is not the right answer, since vomiting typically leads to dehydration and hypovolemia, which activates the renin-angiotensin-aldosterone system and results in potassium wasting. So again, the right answer is D. And that concludes our video on small bowel obstruction and ileus.